Good evening, sir. This is Dr. Fathy.
Yes.
Yeah, hi, Dr. Fathy.
Hi. Hi, sir.
Yeah, hi. So we'll have two stations. One is clinical case scenario and second is the CBS. So we'll have 30 minutes with us. So 20 minutes for the case and 10 minutes for the CBS. So extra 5 minutes I'll like to allot in case of any delay. And whichever questions you sometimes get confused or you don't know, just tell us to pass so that we'll not waste the time. And everything will be discussed in your debriefing session, so nothing to worry. So let me first start with the cases, the clinical case.
Okay.
Yeah. So this is basically a trauma, and we have 6 vignette in here, 7 vignette, of course. So I'll just start with a simple case. So 46-year-old male, he has a history of trauma, and when the patient was received in the ER, the casual emergency room, so he was drowsy and his GCS has dropped from 15 to 11, and he is quite tachycardic. The cold peripheries and blood pressure is on the lower side. There is extensive trauma to the abdomen and the lower right lower limb, and there is massive swelling, bruising, and of course the same site, you can say that looks like a some kind of compartment syndrome also. And after 1500 ml of fluid, the patient shows partial recovery, and the BP has temporarily increased to 88 by 45, and it further drops actually. So this is the overall case scenario. So polytrauma with shock and unstable patient received in the ER. So my questions is purely little bit theoretical. So which guidelines of trauma normally do you follow, and what are the different as per these guidelines? What are your approach, clinical approach to this patient, and what investigation you would like to send, and how to manage him initially?
Okay. Of course, the guiding principles in the initial management would be the ATLS protocol, including A, B, C, D, E, plus cervical stabilization, which comes with the A, to rule out any life-threatening emergencies. The primary survey should carry on with securing the airway, the breathing, and the circulation, which obviously impaired here. The primary management after which primary survey, which would include, of course, insertion of two large bore cannulae, 14 or 16, giving the fluids, activation, the massive transfusion or major hemorrhage protocol, alerting or notifying the trauma team or red code, and going on from there. The other investigation, which we send immediately after primary survey, of course, in this case, whether according to the clinical condition of the patient, whether we are going to go with a fast ultrasound, which is usually bedside, or if the patient condition allows us to do a trauma CT, pan CT or trauma CT to detect where is the bleeding and where is the site of bleeding, then we'll go for the CT. If the clinical condition of the patient or patient seems in severe shock status, then the issue now would go with the surgeons to take him to the theaters in order to stabilize the bleeding, or if we are suspecting there is signs of bleeding might be from the pelvic fracture, then we do pelvic binder and go for interventional radiology for angioembolization.
Right. So you told about the trauma code and code red. So basically, code red in our hospital is a fire. So are you sure that it is code red, in your hospital? Which hospital like you belongs?
I live in UK, so it's
Okay. So are you sure that it's code red? Because as per the international guidelines, the code red should be the fire actually. I'm just checking because
sorry.
I'm Yeah.
So,
So, what are the differential diagnosis of your hemodynamic instability in this your patient? The cause of shock you can think of.
uh, of course, the first thing is bleeding. The bleeding is the first cause, whether bleeding from from the abdomen, from abdominal organ or abdominal vessel, or pelvic fracture, which caused retroperitoneal bleeding. Of course, the other issue, of course, aortic rupture, aortic perforation, and of course, all the other major or soft tissue soft tissue or solid organ perforation like spleen or liver. Hello?
Yeah, yeah.
Okay. That is the cause of bleeding, which is hypovolemic shock, actually. The other causes, of course, might be neurogenic shock. If there is spinal fracture, we have to rule out what's called neurogenic shock, or if there is central lesion. But the patient already recovered, start to recover initially after the fluid resuscitation. So obviously, it will be of lower priority here. And of course, other causes of shock, including septic shock, wouldn't be applicable here. Anaphylactic shock, unlikely, but should be considered.
Can it be other causes? Any other shock you have missed? Very important.
In addition, I mentioned a hypovolemic shock. I mentioned the neurogenic shock. I mentioned, which are the most common. I mentioned anaphylactic shock, which is distributive shock, and sepsis, which are usually distributive shock. There is obstructive shock, which might be due to cardiac tamponade or pneumothorax as well.
Yeah. So, like, just this is more a bit theoretical. So, this is something called as the trimodal distribution of death in a trauma. So, why this? Like, do you have any idea why it is called trimodal distribution? So, what are the different peak you normally observe in a polytrauma patient? So, early peak, late peak, and delayed peak. And what are the different causes of most common cause of death in such peaks?
It's called the triad. It's called usually, or it's bleeding triad or the trauma triad. Usually is the hypothermia, coagulopathy, and acidosis. So obviously, those are the
No,
usually
I
the
am not asking about the triad. This is a trimodal distribution. So there are three peaks in a trauma death: early peak, late peak, and delayed peak. So the early
okay.
peak is because of the major vascular injury. So usually it happens within first 6 hours. So the second peak, the late peak and the delayed peak, of course, they have the reason. So just I want to know whether you have some idea or not. Anyway, we'll discuss that. There is something called as the golden hour also. So let's go to our case. So basically, again this patient complains of severe pain in the left shoulder and thorax. He's still very much tachypneic, and he's obviously the saturations are also on the lower side. The X-ray, there is a normal breath sounds, but barely audible heart sounds. He's still very much breathing very fast and needs 8 liters of oxygen to maintain the oxygen level. His blood pressure is low in spite of giving a fluid of 1.5 liter. There is engorged and distended neck veins, and ABG you have sent, which suggestive of severe metabolic acidosis with lactate of 8.5. And you did a EFAST, and the EFAST image is there. So just describe which is the likely diagnosis which is in your mind and how to
I can
proceed.
see in the AFAST there is obviously severe pericardial effusion. Most probably in this context, most probably it's blood. So it's most probably this presentation we have to think about pericardial tamponade.
Yeah, yeah. So how do you proceed further? And this is the ECG, of
Of
course.
course, at this moment we'll have to aspirate. We have to aspirate this pericardial effusion using ultrasound technique. Usually by the either if you
So
most using
what is this procedure called?
pericardiocentesis, or if there is a
And
surgeon cardiac term, he might think about pericardial window.
okay, so the pericardiocentesis, the technique involves like which window of the 2D echo is usually preferred to do the tapping? And what is the technique called of this procedure?
Okay, of course, usually the most common technique, usually using the subcostal technique, which is using by ultrasound or blindly according to the preference, but usually with ultrasound now, and or the other option that we select another assistant to hold the ultrasound, whether in the apical view, and so that can be give more space for the operator to enter through the needle uh, into the pericardium, but usually with an experienced interventionist, usually the subcostal technique would be the most appropriate thing using a long needle and go through the subcostal. Other modalities, of course, can use parasternal technique, but it usually needs some sort of experience and usually done under fluoroscopy.
Okay. So what are the anticipated complications in such procedures?
In this procedure, of course, the most common complication is failure of the to reach the pericardium and or hitting a wrong organ or wrong vessel, which is usually the liver. In this case, the left lobe of the liver or any of the perihepatic vessels, or hitting the lung and causing some sort of pneumothorax or hemothorax, vascular injury. Of course, it might cause myocardial rupture or injury as well due to this procedure if the needle
So
were
how
not
do you
treated.
know? How do you know like if your needle is going to hit your myocardium? What is the earliest sign?
Usually from the ECG, if we see BVCs from the ECG monitor, we
Yeah.
can see the BVCs.
Okay. What type of ECG is typically described in this case?
What
The
type
ECG is
cardiac alternance?
yeah. Fine. So now you did a e-fast of your abdomen also and the lung ultrasound, of course. So there is a splenic ultrasound you did. This is the ultrasound of the liver in the same patient and ultrasound of the lung. So can you just summarize what are your findings in these particular images?
Okay. The spleen, obviously, there is a fluid between the spleen and the diaphragm,
Okay.
which might include some sort of collection there. So usually there is of intracompartmental bleeding or abdominal bleeding. The liver, I can see that the shape of the liver has been usually it's not the normal shape of the liver, which might indicate that there is some sort of hepatic contusion.
Yeah.
Regarding the lungs, of course, it's not moving, so I cannot judge about the sliding here. But obviously,
Yeah.
I cannot see if it's sliding
But
or not. But obviously, I can see a lot of B lines, which indicate pulmonary contusion as well. But of course, sliding, if there is no sliding, then it might indicate pneumothorax as well.
yeah, and what about this window actually? What do you think here? What do you see here actually? The last
Uh,
image.
uh, okay. I can see a lot of B lines. I can see that I can see the bad sign of the
No,
ribs.
here. You see the here. Like what
Uh,
does it you see? The pleura, you concentrate on the pleura. So there is a breach in
Pleura,
the pleura
yeah,
and
yes,
there are a lot of
obviously that
subpleural
obvious
consolidations are there. Yeah,
consolidation.
contusions.
Yes, sure. Yeah,
So
sorry, I forgot.
contusions, particularly trauma, this is
Yes,
called the
contusion,
contusions. Yeah.
contusion. Yes.
So now, in spite of the fluid resuscitation and blood and your inotropic support, this patient is still persistently hemodynamically unstable. So, what will be your next course of action? So, of course, the
Uh,
first images you have. So, with this
uh,
background,
of course, we have here two three lethal problems actually. We have got lung contusion, we have got pericardial tamponade, and we have got bleeding. So obviously all this should be addressed. Of course, we are going to give him 100% oxygen now,
no,
but the issue with
you have already put the pericardios. You have already done the pericardiocentesis,
you have got the
and
pericardicentesis.
patient is on
Still,
ventilator, but still he is hemodynamically unstable, and this is
if
the hmm.
so we have intubated the patient, we attach him to mechanical ventilation, we have done pericardiocentesis. Am I right?
Yeah.
So obviously now we have to rule out either the hypovolemic shock, which is due to the bleeding, or
Yeah.
obstructive shock due to pneumothorax or whatever.
There
So
is
obviously,
no pneumothorax.
neurogenic shock, no pneumothorax, and there is no, obviously, then we have to either hypovolemic due to the bleeding. I'm going to activate now the massive hemorrhage protocol, massive infusion, or major hemorrhage protocol, massive transfusion protocol, whatever we call it, and we are going to call the surgeons to see if we can shift him immediately to the theaters for stabilization. I have to do the survey about if there is any spinal problem, pelvic problem, because if there is pelvic fracture and this causing this kind of bleeding or retroperitoneal bleeding, we have to apply pelvic binder and do angioembolization via intervention radiology as fast as possible.
Of course. Yeah, yeah. So now you have shifted the patient to the OT, and on the exploratory laparotomy, the operating surgeon, they have found out that the spleen is severely damaged, and they have removed the spleen, and the liver injury, they have managed it conservatively, and then he was shifted to the ICU. And during this procedure, as anticipated by you, so he required a lot of blood and blood product. Of course, he has received this massive transfusion protocol, and then he came back to the ICU, and these are the different lab parameters in the ICU. You see that the hemoglobin is still on the lower side, the platelets are on the lower side, the INR is deranged, and the APTT is also deranged. So, like, what is this clinical scenario like you think of?
Obviously, you have to rule out DIC at this moment, which might be induced by massive transfusion. So, of course, I would at this moment I would do the TEG if I have it, thromboelastogram or rotem
So
if I
there
have
is
it.
something called as TIC also in a trauma patient. So like just like DIC, there is something called as TIC. What is the TIC?
Trauma-induced coagulopathy.
Yeah. So both of course both of them. So to further investigate, you need, you told just now, like what you need for the tests, bedside
I
tests.
do bedside test, of course. I would need, as mentioned, thromboelastogram, TEG, or rotem, in
Yeah.
order to manage, in order to help me to decide in decision what kind of
Yeah.
blood
Correct.
components or drugs, for example, or even if needed, tranexamic acid or something like this. Yeah.
So now this is the different take reports. So just can you describe the what are the different take reports? 1, 2, 3, and 4.
Okay, one looks normal for me. Two, there is
Okay.
increased R timing, which usually due to heparin, might be a heparin effect. A heparin
So
effect, most of it.
it can also be because of the low factor deficiency also.
Yes, low
Can because
factor,
of
of
the
course, yes.
yeah, yeah.
Okay. The three, usually due to usually seen in cases of DIC of or severe thrombocytopenia. Four, due to fibrinolysis, most probably, which
Yeah.
is it's seen in after fibrinolytic therapy. Sir, the answer is written on this. I'm trying to look without looking to the answer. So I'm
Yes,
sorry.
yes, yes. The answer is there. I just wanted to test your
But
knowledge.
I
So
haven't looked. I haven't looked at it. I haven't looked there. Okay. I was
okay, great, great.
concentrating on this.
Fantastic. Great, great.
Hmm.
So now this overnight, this patient remained hypotensive. The drains were quite hemorrhagic, and the night duty doctors reports that the patient is restless and his urine output was persistently low, and the ventilator alarms are typically giving an alarm of high peak and plateau pressure, and also he was on NORAD support, and the urea and creatinine has gone up. X-ray is normal, and this you can see the overall picture actually. So, what is the cause of the low output, and what is this like the clinical state? You can say at
The first
present
thing I'm
right
going to
now.
think about, of course, after ruling out the airway problem, obstructed tube, or anything, or bronchospasm or anything, I would think about compartmental syndrome, acute compartmental syndrome, or ACS. So obviously,
Okay.
this patient has got a surgery and has been laparotomy, sorry, and it was sutured after they finished. So obviously, he might have developed acute compartmental syndrome either due to bleeding or oozing inside from the or increased pressure of the sutures. So the first thing I'm going to do after ruling out any airway problem or breathing problem which might have induced the increased peak airway pressures, I'll give the patient muscle relaxant. I'll try to give him lung protective ventilation. If it was not applied lung protective ventilation, I'll try to limit the fluid intake. I'll make him a nail per mouth or nail per NG. I'll call the surgeons for immediate laparotomy if needed. And
Yeah, fantastic. So now, how do you measure the abdominal compartment syndrome?
most common method in the ICU usually it's through the Foley catheter.
Right. So now the patient had a worsening acidosis and drop in the urine output. So you have taken a nephrologist opinion and he was planned for renal replacement therapy, and you instructed your junior to put a hemodialysis catheter in the right IJB. And after the catheter placement, the patient suddenly became hypoxic and the oxygen parameters have worsened and there is a drop in the blood pressure. And again, the ventilator is showing high peak and plateau pressure. And this is the X-ray which was taken. And so just comment like what is the situation right now? What do you feel?
Obviously, now there is a pneumothorax, tension pneumothorax, which has been iatrogenic, which has been caused by insertion of the dialysis catheter on top of bad lung already. The lung is already contused, full of contusions or congested lung. So obviously, I can see a pneumothorax, which is from the clinical context, tension pneumothorax on top of an ARDS lung, actually.
Yeah. So how will you manage this?
Of course, it needs urgent insertion of intercostal tube, or if I'm trained to do so, or if I'm not trained, I would put two large cannulae, two big needles, two big cannulae, either subclavian, which is old guidelines, the recent guidelines from the ATLS, mid-axillary and the mid-axillary or anterior axillary line, two large bores needles, until someone is trained to insert the intercostal tube comes.
This which intercostal space you will put the needle?
Fourth or fifth
Right.
intercostal space.
Okay. So how do you critically debrief this incident to your junior and to your quality team in your hospital?
Of course, after securing the patient, after ensuring the safety of the patient and that he is safe, we have to do an instant report about about what happened, to see if, because obviously it's a very common complication, which maybe no one made a mistake. It's just maybe something wrong happened during, so that we have to learn from this event. So obviously, ideally, the ultrasound images should be stored and be analyzed in order to know if there's something wrong happened or not. We ask all the persons who were involved in this incident, whether the operator itself or the assistant or the supervisor, to know exactly what had happened in order to see if anything wrong had happened, which we could avoid in the future to prevent the occurrence of this event.
Right.
And
how do you report to your quality team?
It's by writing an incident report. That's usually the writing incident report, and then this would be if there is a computerized system in our hospital, this will go automatically to the quality team. If not, then we write an incident report, inform the quality team or the line manager, and they will investigate and would do what calls root cause analysis. And after this root cause analysis, we'd have some conclusions about this reason, or it's just the iatrogenic complication. And after this, if we are going to apply what's called the duty of conduct, we are going to notify the patient or his next of kin or the relatives about what happened and how we managed this kind of complication. And
there is something called as some protocol is there, for this you're normally breaking the bad news and some kind of critical events. Some protocol is followed. Like, have you heard of some SPICE protocol?
SPICE, yes. Seek more information, ensure patient safety, take initiative, escalate if needed. And the last thing S, which is seek support your colleague in all times.
Correct. So we are done with the critical, like the clinical cases. Wonderful. We have done a good job. Actually, I must say that you have read most of the parts thoroughly in trauma. So let's see the spotters like the CBS station. This is a 10 minutes, so we'll just quickly go through and you have to identify and just give 2 or 3 explanation for the questions which have been asked. Okay, can we start?
Please.
Yeah. So this is the first scan. So just read the scan and tell me what is your impression regarding this scan.
I can see a scan, obviously, of subarachnoid hemorrhage, and there is a loss of white matter and gray matter differentiation. So obviously, most probably this is a subarachnoid hemorrhage in a patient with severe brain injury and obviously
Okay.
brain edema. Yes.
So how do you differentiate between traumatic subarachnoid hemorrhage versus aneurysmal subarachnoid hemorrhage? In a CT
Usually
scan?
from the location of it. Usually the location of the traumatic subarachnoid hemorrhage usually is diffuse and it's not going through anatomical and usually associated with other signs like fracture, skull fracture or lung or intracerebral contusion or extradural or subdural. While aneurysmal, it's usually spontaneous without any trauma.
So what is the immediate priority in the management of this patient and what other treatment, what other investigations you would like to do?
Yeah, according to the clinical context of the patient, of course, in all times, we are going to ensure A, B, C, D, E approach. We have to secure the airway. We have to give. We have to support the breathing. Usually, in the first instance, especially if trauma patient, we might hyperventilate a little bit or at least seek normocapnia in the first 1 or 2 hours until a definitive management is being applied. Circulation will support the circulation, will support the MAP, will seek MAP above main arterial pressure above 80 in order to increase the cerebral perfusion pressure. Will give fluids or bloods if needed according to the patient's trauma or spontaneous disability. Of course, at this point, we'll have to patient should be analogous sedated, deeply sedation, whether with benzodiazepines, propofol plus fentanyls. Sometimes we have to use escalate even to thiopental sodium or thiopental sodium if needed, according to the tiers, what's called tiers. Most of the centers have protocols regarding management of subarachnoid hemorrhage, was called tier 1, tier 2, and tier 3. So, and sometimes even we need to apply anticonvulsant or therapy like levetiracetam or Keppra or phenytoin, sodium phenytoin, and apply and might at this last stage we might need to give muscle relaxant or muscle paralysis as well. Notification of the neurosurgeon is paramount in any stage of the whether traumatic or aneurysmal. And of course, if we are suspecting aneurysm, we have to think about doing what's called angiography, CT angiography for the patient to detect the location of the aneurysm. And according if there is aneurysm or not, the second step will be how to prevent this from happening again, including embolization or coiling most probably. And after this, of course, treating the sequelae of the event, including diabetes insipidus, sepsis, and whatever.
So identify the equipments on the left side and the graphs on the right side, waveforms. The left side.
This is an AVD. This is an AVD, external device, external ventricular device, and these are the ICB waveforms. Can see B1, B2, B3. Usually, this is B3 is the what's called the I forgot the reference, but usually this is the peak and the percussion, and then the diastolic. B3 is the diastolic wave. Obviously, what I can see here in B1, the A, it's a normal trace. B2, there is increased intracranial pressure. And
what?
when B2, because the P2 is higher than the B1.
Yeah. And C?
And C, obviously, there is in case what we see in diffuse delayed or late brain injuries, like in brain death, for example, or all the pressures.
So this C is basically suggestive of highly non-compliant brain, where there are a lot of pulsation, or all the pulsation are being lost actually. So
yes,
this is
yes.
So do you know about the Brain Trauma Foundation guidelines for ICP measurement, and any what are the different waveforms like this Lundberg waves?
Yes, the number of usually A, B, and C, and usually A are the usually the most significant because usually they indicate that there is severe brain damage. Actually,
Okay.
according to what I remember, I haven't revised them for a long time, but yes, sorry.
What is this BTF Foundation guidelines for indication of ICP measurement?
BTF found guidelines is about how to apply the ways of measurement of the ICP, including, of course, whether invasive or non-invasive methods, and different devices which we can use, whether the Bolt or the AVD or the other Doppler methods, ultrasound Doppler methods, and the three waveforms which are being described are those usually needs the Bolt or EVD to in order to, or usually the Bolt, what's called intracranial Bolt, whether in external in the ventricle in the brain tissue itself or attached to the external
No,
without
sorry, I just interrupt. Like the indication of ICP measurement as per BTF guidelines. In which patients you need to...
indications. Okay,
Yeah.
indications whether severe any patient with severe trauma and GCS less than 10 are indication of brain ICP measurement. Patients with patients would have got subarachnoid hemorrhage and GCS or mild to moderate trauma and GCS less than 13 as well are indication of any severe trauma are indication of ICP management if the patient is not conscious. If patient mild to moderate trauma, if GCS less than 13, usually this is an indication for ICP management. Any patients who have got prolonged post-operative patients who have got post-operative after major surgery like brain tumor. This
no. Brain Trauma Foundation typically for the trauma patients.
Trauma patients. I forgot. Sorry.
So any patients with more than 40 years and with a severe grade of brain injury, or less than 40 years with certain signs or symptoms like extensive motor posturing or anything, that patients actually need ICP monitoring. So just go and read this Brain Trauma Foundation guidelines. These are very important guidelines actually.
Okay.
Yeah, this can we identify the diagram on the left and right both?
Okay, I can see now this is an ultrasound of the eye globe, obviously, which is used to measure the ICP, intracranial pressure. Usually it's significant if the diameter between the anterior and posterior part of the retina is usually more than 3 millimeters. So obviously now if you got more than 3 millimeters distance, this might indicate increased intracranial pressure.
Okay, what are the instrument on the left side? What does this signify on the right side? I mean to say.
Right side, this is ultrasound.
Sorry, this one. What is this? What is this? Right. Yeah.
There's some ICP bolt, by the ICP bolt or ultrasound cranial Doppler. I don't know if this cranial ultrasound
cranial Doppler. Yeah.
Yes, cranial Doppler.
Okay. So what are the different non-invasive ICP monitoring devices?
The non-invasive, of course, usually the first thing we're going to think about is the ultrasound, whether cranial Doppler ultrasound or globe or eye globe or ultrasound. There is what's called also microdialysis, which can be used as well to measure the or have an idea of the cancer.
Microdialysis is a invasive. It is not non-invasive.
Invasive.
So you can go.
But it's not very okay. Sorry. There is as well the, I don't know if you are going to consider the epidural as well invasive or not. Epidural is
No. These
invasive.
are
Epidural
all
is invasive.
invasive.
Okay. So obviously
Yeah.
the EEG, then it's the EEG, then EEG and the ultrasound as far as
Yeah,
I know.
and your near-infrared spectrometry, brain oxygen tissue
Spectrometry, yes,
monitoring.
infrared spectrometry, sorry, infrared spectrometry. Yes.
So all these are okay. So of course, these two are very simple question. I'm not going to ask you. So let's go to this case scenario. Just go through the scenario. I'll show you the CSF report after that.
A female who presents to emergency department with worsening headache, neck pain, and back pain, 2 days duration. She also complains of low-grade fever and chill that developed over the past 24 hours. And that she seems more lethargic and has different clinical balance. In addition, she reports 3 or 4 nausea and vomiting. She was diagnosed with HIV positive status and was lost to follow-up. Presently, ARTs,
Okay.
what's ART stand for? Sorry?
Yeah. ART
ART
means
is what?
the antiretroviral therapy for HIV. Yeah.
No, oh, yes. Okay. Sorry.
Okay. Now this is the CSF report of the same patient. So I just want a diagnosis with this CSF and with this background. What do you think? The likely cause of her presentation?
I think either coccidomycosis or cryptomycosis. That's coccidomycosis, the first thing I would think about.
Can it be tuberculosis?
Can I see the analysis again, please? Can be tuberculosis. Yes, from the mate can be tuberculosis because of the fibrin web formation, but TB can be, but usually, or coccidomycosis, cryptomycosis, all of this can be, but usually can be TB as well.
How do you differentiate?
Atypical mycobacterium, yes.
How do you differentiate, like what test we'll send further?
Obviously, there will be some sort of discussion with the microbiologist and infectious disease, but obviously, we're going to send for Zell-Nelson stain, BCR for the multiple fungal and atypical organisms, and obviously, if the PCR, whether for TB and other atypical mycobacteria, and other for the fungi as well, and of course, need discussion with the microbiologist in order to decide which thing I actually have to request. In addition to, we will have, in addition, another viral, of course, viral PCR as well. But in addition to this,
Okay.
we'll have to.
So what are the causes of aseptic meningitis? Do you know?
Aseptic meningitis in the context of HIV or in general?
Sorry?
In general, aseptic meningitis in general, or the context of HIV. Aseptic meningitis, and just aseptic meningitis include of course, might cause a fungal causes. Toxoplasma.
No, we'll discuss that. Just find out, just comment on the MRI, cervical MRI.
Okay, I can see now fracture of the spine at the level of the.
Okay. How do we intubate this patient? How do we intubate?
Of course, she will need the cervical stabilization, inline stabilization. In addition to a video scope, if available, I need the most experienced one in dealing with this kind of cases, usually a senior anesthetist in addition to senior intensivist with us. We need at least assistant to stabilize the neck while we are intubating the patient. We might need endoscopy. If the patient is stable enough and we can secure the oxygenation, we might need, obviously, either in addition to the video scope, we might need a bronchoscopy as well. So it depends upon the qualifications or the training of the operator, in addition to the resources what she has got inside the hospital in order to intubate these patients safely.
Okay, identify this.
This is intra-abdominal pressure monitor.
Right. How do you, at what level you transduce?
At usually at the level of the pubic rami.
This both the instruments are used in trauma patients.
This is massive transfusion.
Yeah. What is that called
device.
actually? What is that called?
I knew that. I was just saying yesterday. I saw it yesterday, but I forgot. There are two types of it, but I forgot the. Sorry, but massive equipment for massive transfusion, but I forgot its name. Sorry. Yeah.
Okay. Fine. This is. What is this equipment?
This is for the invasive temperature monitor or what? Maybe
No,
most
no,
probably
no.
not for COX-2 or ITU.
No. It is for some other purpose.
I'm trying to figure it out. I haven't seen it before. Sorry.
Okay, fine.
I'm sorry. I mean, it's not.
Oh, no issues.
Sorry. Maybe sorry for the intracerebral oxygenation. I presume, right? Maybe for intracerebral oxygenation. Cerebral oximetry.
Yeah. Okay, fine.
But the one we have in our hospital is non-invasive, not invasive. So I didn't see the one.
Okay, great. So no issue. So again, we'll have the discussion in the your debriefing session. But of course, so great. So
thank you so much.
Let's see you again.
Thank you for your time.
Thank you.
Thank you so much.
Thank you very
so
much
for your time.
Yes.